And there we go. All right. And I'll give you a little history or background for the Quad County Urban League. Then we'll move into the introduction of our community health worker supervisor. And from there, we will go to the introduction of our guests, panelists today, as well as and then move into our discussion. We'll by that time, I'm assuming that we'll have more of our audience here. I see more folks are joining us. And so, as like I said, as we get started here, I will just begin and again say welcome. We're representing the Quad County Urban League, which is located here in Aurora, which is where we are located. And we have been an establishment for 45 years, where our CEO president, Theodia Gillespie, who has been at the helm for approximately 29 years, running this organization in order to serve our communities. We are a civil rights organization, as well as one that provides and supports the equity of African American women and other minority groups for fair housing, equitable jobs, I should say, and careers, as well as our youth and education, young people for education. The areas that we truly do our service in is workforce development, youth and education, as well as our small business administration, and of course, our community health workers, which are our health equities portion. Again, we're excited to be here tonight. Our CEO president does send her regrets. She had another meeting that came up so that she was unable to be here with us tonight, but she is, of course, with us here in spirit. So with that said, I am going to now introduce our supervisor of our community health workers, Barbara Collins, who has invited many of you to be a part of this conversation. And so, Barbara, I'll turn it over to you.
Okay, thank you, Elisa. Yeah, I'm Barbara Collins, and I am the supervisor of the community health workers. And it's four of us that we work a lot in the community. And with this pandemic, we have been instrumental in helping people that have been affected by COVID. People have been affected in so many ways, whether it's just being in isolation and not being able to get food, or just having some mental health issues or things like that. So what we do is we gather the resources for each client that comes through us through the health department. And what we do is we definitely go above and beyond to try to get them their needs. So we get resources from grocery stores. We get food delivered when they're in isolation. We recommend for counseling or different kind of therapy that people need. So we work collaboratively in the neighborhoods, but we also, right now, we're covering Region 7, which is Will County. And the majority of that is like Bolingbrook and Joliet. And those are places we are focusing on as far as the people that are coming to us. So right now, we are just in the process of doing more outreach in the community and just trying to encourage people to get vaccinated, because I know that's the key to getting a handle on this pandemic. So I just thank all of the CHWs. It's like I said, it's four of us. So we are definitely dedicated to helping the people that need our help. So with that being said, I'll turn it back over to Elisa.
Thank you, Barbara. And again, as she said, this is actually part of the work that the Quad County is doing. We have a grant that we received from the Illinois Department of Health. And so with that, they provided us training and that so we can go out and support those who have suffered from COVID and the effects of it, as far as even losing their jobs, or like she said, just providing them with resources. Thank you, Barbara, for that intro. So with that, I'm going to, I took down my flyer, but I'm going to put it back up because I want you all to see our guests, or even, I'm sorry, you know what, as I introduce you, if you could just turn your cameras on, I will let you know who's up when I get ready to give your introduction. So Juliet Alcantar Garcia. Juliet, I thought I saw you join us. Okay, well, it's all right. I will, oh, there she is. I see you turned on your microphone. This is one of the questions that we had. Are you able to turn on your camera? You can chat me if you are not able to. Welcome, Dr. Jasmine. We're just getting started, so you have not missed anything. All right, I am trying to, nobody's talking to me, so I'm going to see if I have put some setting here preventing you all. Let's see. Mic, yep, and allow camera. There we go. All right. So you should be able to turn on your cameras. Our panelists will be present in their cameras as we have this conversation, and then we would ask that our guests, or those in the audience, oh, you're still not able to turn on your camera. Okay. Let's see. And Dr. Crawford, were you unable to still turn on your, okay. No, you don't have to leave. I think it's my setting, which I am trying to correct. Yeah, because it actually, I had allow mic and allow camera, and now it turned back off again. Let's see. Okay. There we go. Very good. There they are. Very good. Welcome, everyone. So I'll start off with Juliet Alcantar Garcia. Juliet, thank you so much for joining us. Juliet works with the Immigrants of Solidarity DuPage since June of 2011. She is a community health worker and Casa DuPage worker with the Center for Social Work. She helps people with COVID-19, workers' rights violation, and coordinates the organization's vaccine clinics at different sites with the IDPH and IEMA. Juliet is also a coordinator for the mobile food pantry market at Casa DuPage with the collaboration at the Northern Illinois Food Bank. Ms. Alcanta Garcia is a mom of two teenagers, teenage boys, where the oldest lives with autism spectrum disorder. Ms. Juliet Alcantar Garcia is a part of our panel. Welcome, Juliet.
Thank you.
You're very welcome. Dr. Henry Lee Allen. Dr. Henry, yay, there he is. Dr. Allen, he has been an active as a sociologist for nearly 4 decades at Bethel College, Calvin College, which is a university now, the University of Rochester in New York, and the Rochester Institute of Technology, as well as locally here at Wheaton College. Dr. Allen's research, he has taught courses in sociology of education, science, and urban life courses in criminology, including violence in minority communities, violence against women, and the sociology of hate. That's very interesting. Would you say time out? That's enough? That's enough. Well, I'm going to read one point that I felt was very important. And I feel like it's all very important, but Dr. Allen has published over 40 scholarly writings, articles that include the sociology of science in Canada, Israel, Scandinavia, and the United States, the scientific illiteracy in current public policies, and an article on the future of sociology for Russian Academy of Sciences. He attended the Nobel Enterprise Summit in this last year in April. Welcome, Dr. Allen. Welcome, Dr. Allen. Thank you for being here. We have, hello there, Maggie. I saw you join us. We have Dr. Larry Crawford. Dr. Larry Crawford is no stranger for us as a panelist. He actually joined us for our mental health panel that we had a couple months ago. He gives a very unique understanding of, I'm sorry, who was that? I didn't see your note. Gives us a very unique understanding of his role. He said, what does my role look like as a truancy specialist over the last 18 months? Typical fears of the pandemic. People are really dying. Truancy as required the law. Refusal to send their children to school. Parent, caregiver, general concerns about any kind of vaccination. Many parents have always refused vaccinations even before COVID-19. And then compromised immune systems, infant, elderly, family members in the home. Finally, negligence of other parents who are sending their unvaccinated children to school. And we saw that increase right when school went back in September, and then again in November were the increased numbers, and again here just recently in February with the number of children actually getting COVID-19. Dr. Larry Crawford is a truancy specialist for the City of Joliet in the Public School District 86. Welcome, Dr. Crawford. Reverend Crawford, sorry about that. Thank you. Dr. Mark Gomez, MD. Dr. Gomez, known as Dr. G, is a renowned licensed board certified internal medicine physician practicing in Naperville, Illinois. He is the Chief Executive Officer of MDG Wellness Limited, a firm that is dedicated to delivering health and wellness programming via web, social media, digital media, public-private partnerships, and corporate wellness. You'll have to tell us more about that. I actually did, during COVID, experience calling a digital doctor because I was out of state and I was feeling sick. And I actually did end up with COVID, but they were just kind of counseling me over the phone on how to do that and take care of myself. So that practice is very well needed now, especially with our remoteness. MDG Wellness LLC licenses and produces all relevant content of the Dr. G brand, building trust, delivering truth. I think that's relevant to tonight's subject. Yes, yes. Doctor, I know you want me to stop, but I'm not going to. I'm going to keep going. Dr. Gomez is the co-creator, co-writer, and host of Health 360 with Dr. G, a health-driven podcast, and To Your Health with Dr. G. His podcast features conversations with experts that aim to inform and inspire healthy living. I'll stop there. There's plenty more. But what I would like for you to do is, what I didn't have is put your podcast information in the chat so that folks can have opportunity to check you out. All right. Thank you so much. He is a member of the Edwards Hospital staff at Naperville, Illinois. And finally, and not least, we have Dr. Wilnice Jasmine. Dr. Wilnice Jasmine. Dr. Jasmine is the medical director of behavioral health at the Chicago Department of Public Health, where she is part of the leadership team responsible for the City of Chicago's initiatives in the areas of, this is huge, violence prevention, substance use and recovery, and mental health. For Chicago's COVID-19 response, she worked on providing safe isolation housing for residents who could not safely do so on their own. Dr. Jasmine is the health department's lead on initiating Chicago's wastewater-based epidemiology project to serve as an early warning system for the detection of SARS-CoV-2. Or is that COVID-2? Am I saying that right? Or a COV-2?
SARS-CoV-2.
Okay. And is the 2 for 22, or because I know 19 is for 19?
Oh no, so two because it's the second kinds of SARS virus. The original
Okay.
SARS was found in the early 2000s.
Okay, got it. All right. So she specializes in both family medicine and preventive medicine for public health. Dr. Jasmine is an alum of Johns Hopkins Bloomberg School of Public Health and the Cook County Loyola Family Medicine Residency Program, where she served as chief resident during her final year. And she also completed the primary care and psychiatric fellowship program at University of California, Irvine. She just completed. Congratulations. All right. Thank you, everyone. Thank you all for joining us. Juliet, I saw Dr. Maggie Rivera join us as well. Welcome, Dr. Rivera.
I'm here.
Yes, thank you for joining us. We're glad to have you. All right, I'm going to get
Thank
this
you.
table topic started. Today is our table talk again. We started this table talk. The purpose of of this is, one, as the community health workers are in the community, they've heard the conversations from our constituents, from the clients, from the participants. And so our efforts are to educate the public about these items. Quad County serves both the four counties, DuPage, Kendall, Will, and Kane. And so, again, a vast number of people, right? So we want to be able to share with them action items. I pose the action question at the end of our talk, but usually throughout the talk, there is plenty said that people can take action on. So with that, I'm just going to go ahead and get started. So welcome again to our table talk. The first question that I have, and I didn't have this down, so if you could just briefly answer, what caused you to go into the health profession, medical health professions? And I'll start with Dr. Gomez, because I feel like, and I didn't get the stat, maybe one of you know it, the number of African American doctors or even Latino doctors, it's such a small number. I've been trying to find a doctor in our area. I don't know how long. So,
Mhm.
Dr. Gomez, what caused
Yeah.
you to pursue your medical career?
So again, my name is Dr. Mark Gomez. First of all, can you hear me?
Yes, we can hear you.
Okay, wonderful, excellent. My name is Dr. Mark Gomez, Dr. G, and I actually had that statistic for you, by the way. Just to piggyback on what you said, the number of Black physicians in this country has not changed as a percentile in the last 120 years. That was actually published by UCLA, April, I believe, of 2021. So when African American representation of the population is about 14, 15% of the total population, but 4% of all physicians are African American. And for African American men, that number has been flat in the last 70 years. We're seeing a growth in women to be about 2.2% for women, a little bit over 2% for men. And just to give you a piggyback ride, just a piggyback on that, when I was born in 1978, the 1978 to 79 school year, academic year for African American physicians in this country, this is as far back as the data goes that graduated medical school, there was roughly over 600 Black graduates in the year 1978 to 1979. When I graduated, that's in the whole country. When I graduated medical school in 2004 at Loyola, there was roughly 1,000 total Black graduates in 2004. And now, as the most recent year through the American Association of Medical Colleges, I believe last year's data or the year before, either 2020 or 2021, depends when they updated it, the number is only 1,400 total Black graduates in that class. So in my 43 years of living, the number has only essentially doubled, barely more than doubled, as the number of graduates of African American students from medical schools in this country. And I will say one other thing. Back in 2006, there was an expansion of the number of the number of open medical school positions in this country from roughly 15,000 to about 22,000 students per year. As far as African American participation in that, the number of matriculants barely rose, even though the national pool of open seats expanded by about 33%. So this is why I went into health. I love looking at stats. I love looking at
Good.
I love looking at data. I love looking at our people. I love looking at progress. I love looking at inequities, and that's why I'm so glad to do what I do. So I went in it to help others just like everybody else did.
Excellent. Excellent. I'm glad you had those stats. I knew someone in this group would.
Yeah,
So I appreciate that.
you
Dr.
bet.
Allen, tell us why you've been doing this for 40 years. And you are on mute.
Can you hear me now?
We can hear you now. That's technology.
Well, I'm the old man. I actually retired from Wheaton College back in right before the pandemic in
Yeah.
2020. But if you want to know what started me on my odyssey looking at these issues, I'm a sociologist, and what got me going as a young youth was Marvin Gaye's "What's Going On."
Right, right.
My career is a fulfillment of trying to deal with those issues, whether they be medical, whether they be crime, whether they be education, whether they be. And so that's really the motivation. I'm a Motown kid, not a hip hop, not a rap, Motown kid. And I've been at it because the problems that we saw back in that day still persist. They may be better in some areas, but they're also more entrenched in other areas. So for me, to pursue justice, I'm also a believer in that famous Micah 6:8 verse that says, "What has he shown you, O person? What it is that God requires of you? Do justly, love mercy, walk humbly with your God." Those are the things that motivate me in all the work that I do.
Excellent. I love that. That's brilliant. Dr. Rivera, welcome
Yes.
again. What has caused you to take this plunge into the medical arena or healthcare arena, I'll say?
Well, actually, my doctorate is in education, not
Okay.
health.
But I know that you
However,
work in the health arena now.
yeah, however, in my other past experiences, I was a clinician for a mental health clinic. So my journey began in the substance abuse field in counseling Latinos in the McHenry County area where I worked in community health, mental health clinic. So I started becoming very interested in other aspects of health because I found that mental health goes hand in hand with many other illnesses. So I started just becoming more involved in those different areas. And then, as you would have it, when I got offered the position that I have now as the CEO for the Illinois Migrant Council, which is a statewide non-for-profit organization that provides services to migrant seasonal farm workers, immigrants, and refugees across the state. One of the big programs here that we house is health related. So we work with all different types of health. So we have what we call promotores de salud. So these are the health promoters that work in our communities. And we do many different programs, anywhere from diabetes prevention classes to diabetes maintenance management to how old is your heart events. And most recently, we became the pioneers in the pop-up COVID vaccine clinics. So we started doing a lot of the outreach, a lot of the pop-up clinics, and along with that, we embrace different services that we offer during the clinics in the health field, such as blood pressure, diabetes, hepatitis C detection, HIV testing with other organizations. So that's kind of what my journey has been in the health field. So it's a different kind of doctorate, but it's still in education.
Excellent, excellent. I'm going to ask if anyone is not speaking, if they would turn their microphones off. We have some background noise. Thank you, Dr. Rivera. I appreciate that. I want to give a shout out to your organization. They recently, just about a month ago, maybe 2-3 weeks ago, had a pop-up vaccine clinic and gave 150 vaccinations.
Yes, yes, yes. Yeah,
Amazing.
yeah, and
Hallelujah.
along the way, we have had probably about 60 clinics throughout since the pandemic started. Well, since the shots became available,
Yeah.
and all of our clinics up until April, when it just boomed, where everybody started doing clinics, our clinics were never less than 1,400 people at a time.
Yeah.
Wow.
And that's amazing because I know we've had several, we've had a few, and each time, unless we had them register or, whatever you were doing, we want to know because our clinics they were not well attended. So we appreciate, getting out there and using that mobile vaccination van and getting folks vaccinated in that number. Amazing. Thank you so much.
You're
So
welcome.
I'm going to move to Dr. Jasmine. Dr. Jasmine, what caused you to be in this healthcare field, as well as I know you have the behavioral as well as psychiatric that you've just completed?
Yeah. So for me, initially, I remember during my first week of undergraduate college, 9/11 happened, and I was attending school in Manhattan at that time. So during that time, I got to see the impact that the New York City Health Department made in terms of providing aftercare services for those
Sure.
members who were exposed to all the building debris. And for me, I was very surprised to see that physicians were working in a health department. I never thought of that as a possible avenue
Mm,
for physicians. I knew I liked science. And then I entered medicine because I like interacting with people. And I just like meeting people. And then I chose family medicine because I want to be able to provide care to a whole family. So,
sure.
so from the beginning of one's life to the end, that's something that I'm very passionate about. And then working for the health department here in Chicago, I get to focus on substance use and recovery programs, the actual initiatives in the city that we carry out to try to find data, especially with the opioid overdose,
Sure.
and trying to work with organizations that are in this field to help coordinate their activities and see how we can expand their activities. And then I know for me, working with vulnerable populations is something I'm very passionate about. And
Hmm.
so bringing in the mental health aspect, we know that many people, they who have serious mental illness, they often may also have a co-occurring substance use disorder. And those who are extremely ill, you may see them cycling, have unstable housing, or may be experiencing homelessness or cycle in and out of their emergency department, or
Hmm.
even interfacing with the criminal justice system because there's no true like mental health safety net for them.
Yes.
And
Yes.
so, like for me, I want to impact policies that will help bring services to people who need them so they can actually achieve their optimal health.
Excellent. Excellent. All of these are so commendable is the word I'm looking for. Dr. Crawford, I know you're still there, and I don't know why I keep calling you Dr. Crawford. I saw your name as a part of the Aurora African American Health Fair that we used to have on an annual basis. Did you ever attend that?
Um, not at in such a way that I had a table or as a vendor, but I have attended that.
Yes. Okay. Okay. Well, with that said, what caused you to go into? I know you're in the truancy care, but I know that also takes in the mental health of our students.
Well,
Tell us more.
my background is really special ed as it may be, and I was a behavior specialist for a lot of years. Well, I've only been in Illinois since 2001, and no, I am not responsible for 9/11 because that's when I came in August, and then a month later, things blew up. I had
Oh,
nothing to do with
wow.
But no, I prior to coming to Illinois, I was a behavior specialist. I've always been in. Most of the time, I've been in education. When I got out of school, I was in municipal recreation and just always have dealt with families and children. And ultimately, I'm not necessarily a PK or a preacher's kid, but my mom was, and my dad were just very faithful in practicing their faith. And so in the economy of just moving that passion into my vocation is kind of how I landed here. And I was ordained as a minister in Oklahoma, and then again ordained in Illinois. And so ultimately, as an educator, I've done truancy here in the Joliet school system since I've been in Illinois. So when you start talking about some of the dynamics that we're going to be talking about today, I deal with them with people who are experiencing what we're talking about, the disparities as it might be. And as a minister, certainly you have those kinds of conversations on a regular basis. But yeah, and the other part of it is that my baby sister is an MD. In fact, she's a psychiatrist, and every family needs one.
Yes, I agree.
And since I've been here, because my sister's a doctor, I've been very deliberate about making sure that my personal, what do you call it, care physician was an African American female. Yeah, so I've been very deliberate about making that choice.
Excellent, excellent. You know what? You all have mentioned and brought in the family point here very well. I know the flyer initially said generational racism, but I intended it to say what it says now, generational impact, because as you all have said, some of what happens as far as the disparity can start in the home, where the way we think about going to the doctor, the way we eat in our own homes, the way we care for our children, the way we even may not have a primary care physician. So with that, I'm going to go with that first question. And again, as I mentioned to you in my email, the questions are really just to kind of spark our conversation. Oh, you know what? Barbara is warning me. I forgot. I actually have a video for you. I have a video, and then we'll start our conversation. Here, let's see. It was very appropriate. And where is it? Oh, here it is. And hold on, let me just share my screen. This is a woman's testimony about her health, as well as how her neighborhood changed. And yeah, can you all hear that? First of all, can you hear the video? No.
No.
Oh.
Okay. All right, I actually know how to do this now. It's not there. It's the share screen. And to turn on the speaker and turn this on and select. Okay, here we go. Let me know. Can you all hear? Yeah. Okay.
Now,
The volume a little bit.
Yep. They don't sell anything but the wrong things. You cannot deny the impact that it has on people's health. I have been in West Baltimore my entire life. As far as money, my mother didn't have any money. I don't want to say she was poor. I'll say low income. Poor we were, though. In the 50s, we didn't have many choices as far as healthcare. The healthcare system then was limited. It was not good for us. And medicine costing so much that my family says sometimes, will I eat or will I pay for my medicine? Oh, I just love my daughters when they come over and we get together and we cook and prepare meals together. It's healthy meals. When my oldest went to college, she came back with a different diet.
Now what happens is if I do a meatloaf, it's turkey. instead of ground beef. You know, I make spaghetti, I make chili, stuff like that. It's with turkey and chicken. We grew up, we ate pork. We ate bacon, we ate a fresh shoulder, we ate pork chops. I did not think it was not healthy eating. Right. Because this is what we were accustomed to. I was in denial. I didn't want to face the fact that I was becoming a diabetic.
The impact is the fact that my family ended up with heart disease, emphysema, diabetes, cancer. My mother's sister, her daughter, died of diabetes. She was an amputee. My mother died of a massive heart attack. And
to address health disparities, we need to understand why they exist, that they're not due to one single factor. They're the result of policy decisions we make as a society. They're due to the environment, health education, insurance and access to care, access to healthy food, and stress. Those stresses are actually experienced disproportionately by people who are poor and people who have been historically disadvantaged in this society.
solutions to these problems cannot just be medical, it's systemic. And that means everybody has to get involved.
If we want a nation to be strong, the people in that nation have to be healthy. They have to be well. If there's anything that we can do to stamp out disparities, we need to do it by any means necessary.
Hi, Ms. Simmons.
Here at East Baltimore Medical Center, most of the patients are underserved.
We need nice deep breaths in and out through your mouth.
Michelle is a terrific success story. There was actually a year where she had lost her job, and before she found a new one, she had no health insurance. And she still managed to buy her medicines out of pocket, paid out of pocket to come and have doctor visits. She was really invested in her own health. That's something that Dr. Cooper's research is looking at, why patients don't invest in their health like we wish they would.
The next thing on the agenda is the community update, so I'm going to turn. Michelle joined our community advisory board in 2011. We provide education to the community about health and about research. We offer training programs for community health workers. We can be sure that we are meeting the needs of people appropriately and that we're not leaving out certain groups of people that have traditionally not been included in conversations related to healthcare. Our strong relationship with the community is just essential. There's no way that we could do what we're doing without their input. And my work is just one of many initiatives here at Hopkins.
Good to see you. Ms. Simmons is a great example of what happens when we get it right as clinicians and as an institution.
I am a fighter. I am a believer. I stand for what's right. And what's right is people's health. And I will never give up as long as I have breath in my body.
One of the things that is so important is that people have what I call a liberated future. And it's hard to be liberated when you're not healthy. And when I say liberated, I mean freedom to be all that God meant for you to be. When we don't deal with disparities, then what we're doing is denying people an opportunity to give back to the world. So we've got to fight it. We've got to fight it with everything we've got.
All right.
Wow.
Right.
Good stuff. Good stuff.
Powerful.
Comments. I'll start out with comments first, because I mean, she said a lot, right? She talked about disparities. She talked about in the home. She talked about systemic racism. They talked about why patients don't invest in their health, and are they just accustomed to tradition? Go ahead, Juliet.
Yes. This really came home. I personally, you know, and things that also my mom went through. She passed away in 2016, and I strongly believe a lot. Even though we tried, we did have insurance for her and everything. There were things we didn't know could have been done, and I think we need to make sure we're informing people of what happens when they don't have their medicines? You know, what happens when they aren't able to get their insulin? The long-term effects it's going to have, where it could lead to death too. And
Wow.
my mom was just in her early 60s, and she had kidney failure. But we learned that earlier in her 40s, something could have been done. I forget what it was, but it was a surgical intervention that could have helped her not achieve the kidney situation with her lungs also. So,
so you're saying lack of education and the need to inform can be a barrier to getting health care, just because we just don't know what to do.
Yes, and a lot of it is also recently. We were just at a hospital, my colleagues and I, where we learned that what was going on was a big misunderstanding. And the family wasn't getting the information in their language. Son, the young man, is trying to translate and trying to put all these medical terms and everything to their family, who only speaks Spanish.
Sure.
That was hard for him, and he was glad that we stepped in to clarify what was going on. We were able to get the doctors and the hospital, to say that they were not going to let this gentleman go until he was ready. And we were happy. We were happy that the only thing that was going on there was the language barrier that wasn't getting across to the family to what was going on with the husband, the brother, and the father. So.
Well, that leads me into my question. What types of barriers exist in the medical community that you've experienced in servicing the African American and Latinx communities? Again, language barrier is huge, right? I'll go with Dr. Jasmine.
Yeah. So language barrier, not just between English and another language, non-English language, but even the jargon physicians use with patients, making sure you're speaking plain English.
Yes.
Sometimes we're taught to ask if patients understand, but sometimes you have to understand could be a power dynamic in the room. So someone may say, yes, they understand when they don't. So I always encourage patients to ask questions as many times as necessary, and it's their right to understand what's going on. It's not an imposition to ask for more clarification. That's why we're here for. So we can't do our jobs effectively unless we know we're all on the same page.
Wow, you said something so powerful.
Yes.
There. A power dynamic in the room. Now, are you saying because I'm the doctor and you're the patient and I know best and you just listen to what I say? Is that what you mean?
A little bit of both. Sometimes it may be from the physician's point of view, or it could be from the patient's point of view, being intimidated too, or thinking the physician does know a lot more about health than they do. I think every individual should be empowered to know that they're the experts of their body.
Okay.
And that the physician or provider is a partner in trying to help them maintain their ideal state of health.
Statement there. They're empowered to be the experts of their body, and that the physician is a partner in their health care. That is huge. Dr. Crawford, go ahead. Doctor, you're gonna be a doctor tonight.
Go prophesy.
I'm prophesying over you.
No, and that's what my sister tells all of her siblings, as it may be, is that make sure that they speak a language that you understand. You know, don't let them be too medically terminology speaking to you, and you say, no, wait a minute, put this in Larry talk. Now we got to have this in Larry talk so that I can understand. And the other part of that is sometimes my pride gets in the way. Is that, you know, I established that, I think Sister saying, I established that power or situation as it me, or lack of power. And I don't want you to know that I don't know. And so I pretend that I understand what you're talking about. And that's something that we face often, especially in that situation where you're saying, and the doctor saying that you got the heebie-jeebies, and you go, oh man, I do. Instead of saying, what are the heebie-jeebies? You know, we pretend that we know stuff that we don't know, and so we deal with that a lot. You know, my sister says, don't go in there and not be honest. Is the other part of that.
Yeah.
Be honest with what's going on. Don't, if you're not taking your medicine like you're supposed to, you say, well, I just, you know, no, I didn't take it. Did you pick it? No, I didn't even go fill the prescription, you know, and it's amazing how many times people just straight up lie. Say, yeah, I'm taking it every day. I feel great. You know, that kind of, I'll stop right there, but because I'm just honored to be around some real doctors here, you know.
Yes.
If you want me to preach? No, I have some other things that I'll share, but in the economy of what
I know, I see Dr. G is over there, kind of got that thought pose. What are your thoughts?
It's no, you know, it's interesting. I think about you know, I want to make a point about, you know, there's just so many barriers out there, and we have to start somewhere. You know, we can't solve all problems, but we're here in service for everyone. We are still people helping people at the end of the day, and that's a great thing. Why we on this panel do what we do, but we don't ask for anything in return. We do it because we love doing it. When you start, when you're part of something bigger, you actually make a hormone, and it's called oxytocin, and we call oxytocin the love hormone. And oxytocin in and of itself confers longevity. And when you're so part of something that is just so awesome, it's good for you, as opposed to when you're lonely and isolated, that actually leads to earlier and poorer health outcomes. And so this is a community helping community. We just need more people that are in the capacity to have decision making or be providers in the model too. That's the one of the simplest ways I say, how can you end barriers? We need more people like us to have influence in decision making and policy making. That's all I want to say.
Wow.
Dr. Allen, I know that policy making and all of those things has been a part of your history. Tell us more.
Well, there are two things. One, as I have observed interactions between physicians and patients, I sometimes I sometimes see a little fear, maybe on both sides. The doctor is fearing the patient. And there have been books and research on this issue, especially as it relates to African Americans and low income or urban African Americans. People have this bias, this fear, this lack of respect that we see not just in doctors, but we also see that in law enforcement officers. And also, I think, as has been said, the communication issue, the issue of cultural competency, the issue of sustained interaction. I mean, you get to know a doctor if you interact with them over a period of time. That's an issue. There's a sort of apprehensiveness. When I go to the doctor, I sweat. And so my doctor is always asking me, why are you sweating? I said, because coming to this place makes me nervous. I am apprehensive. I see you guys with all your coat, whatever. So it's a lot of symbolic things that are going on and so forth. Now, I have hope. I work with a group, the National Academy of Sciences, Engineering, and Medicine. And as Dr. Gomez says, there is hope at the highest levels. Deans of medical schools, it's dealing with issues of racism, mental health, and if we could just bring a connection between what's going on at the national level and what people know for practice at the local level and the regional level, there is hope. Things could change. But I think all, as my colleagues have already said, there's a lot to learn. There is a journal, and I'm sure the doctor knows, of racial and, and ethnic health disparities that talks about all these issues. If you go through it now, you can see articles on COVID, before COVID, after COVID, racism, mental health. So there's a lot of things that are happening now. Let me be quiet.
Well, you're gonna drop the bomb on us, the racial and health, ethnic health disparities. I may have found that article. I don't know who printed it or brought it up in our.
It's a journal.
It's a
many articles. It's a journal.
I have. It's called the website I was using is healthaffairs.org, and they have multiple articles that they are, and that may be different than what you're speaking of, but there were several articles there that I found concerning the disparities, and they talked a lot about the systemic barriers that we have where policies. Okay, yeah, I didn't read that. But definitely there was talked a lot about the systemic things, such as just having exposure to health harming conditions within their community. Again, policing, causing a lot of stress, causing the stress that can, and just being African American. And depending on, of course, your neighborhood, if it's somewhere where you're navigating getting home safely versus just pulling up in your driveway and pulling into the garage. You could have different environmental things that can cause your healthcare to be at risk just because of your environment. So we definitely see the environment can be a barrier. We can see that as I think her name is Patricia or Michelle in the video, that her eating habits were a barrier. Just think, I'm not giving up bacon, FYI.
Let me give a shout out. That Dr. Lisa Cooper is my wife's cousin. I know Lisa. We're part of the family. So
wow.
Now I'm going to ask the doctor from Johns Hopkins. Obviously, she probably knows her. There's a connection there.
When I read her biography, I was like, I wonder if she knows these people. Were they familiar? Dr. Jasmine, were the people in the video familiar?
I met Dr. Cooper about twice while I was at Hopkins. Yeah.
Okay. Interesting.
Yes.
So Lisa, I told you I left a message for her. That's the one I did call and leave a message for her as well.
Oh, I see. Okay. So in thinking about that and your experience being at Johns Hopkins, do you see, because I know I read a lot, and of course they reference Johns Hopkins a lot, and breaking down those barriers and making healthcare more inclusive. Where the patients, as I think what you said, are empowered to own their own health care. Are you seeing that even in the city of Chicago and the different areas that you've worked in? I know that's a huge question, but just in your arena, perhaps.
So for me, I trained at Cook County. So my clinic was the Inglewood Health Clinic.
Okay.
And so a lot of my patients lived in the area or had a connection to Inglewood. Maybe they lived there previously, but they still continued to receive their health care at our clinic. We got a lot of, I guess that's how I got to learn a lot of families who had ties to Inglewood during my 3 years there. So for us as a program, we would go to health fairs or other events like the Bud Billiken Parade.
Yes.
To talk to students and children and their parents to try to encourage them to prioritize health. Usually it's not as big of a barrier for younger children. Schools require either physical, when it comes to sports, or vaccines in order to enter the class for the year. But as people get older, so young adults are pretty difficult to entice to come and get their regular health care because they feel fine. But it's always that saying, an ounce of prevention is worth a pound of cure. So making sure that they're there to talk about how they should set themselves up for a healthy future. I think that's important.
So I'm going to give my own little testimony here, even about just weight. And I realize, even as the woman was talking about, eating pork chops and pork shoulder and bacon and all of those things, that what I've learned just from my husband, he's been practicing intermittent fasting, and just learning from a homeopathic doctor that as you continue eating certain things throughout your life, it changes the DNA of your body, and it actually changes then the way your children come out, if depending on how long you eat. So like I think about small children eating chicken nuggets from fast food every day, or French fries, and the preservatives and the things that go into the food. I'm going back to my nutrition class that we just had for last month. That was our topic last month. But it was just so interesting. One of the doctors talked about how food can, be a barrier within your health care.
Mm-hmm.
Yeah.
It is.
Yes.
Dr. Gomez.
Okay.
Yeah, I was going to say it is. And I love, by the way, you mentioned the concept of intermittent fasting, something that's actually being more of a conversation in the African American and certain Latinx communities, as I kind of try to keep my pulse to the movement of what's happening. We certainly know that those communities have higher rates of obesity, hypertension,
Yes.
and even high cancer rates. So when the concept, briefly put, it's very straightforward. So intermittent fasting, it's an eating pattern that cycles between periods of fasting and eating. It doesn't actually say what to eat, but it tells you when to eat.
Yes.
And so hopefully during that time, we don't need to go into any specifics of that, but hopefully during that time, you're eating the foods that help to fuel your health. And so we think about, number one, when you think about the healthy plates, what should you put on a plate? People ask me this all the time. I say, number one, consume a variety of foods, without a doubt. Number two, fill at least half your plate with vegetables and fruits. You want to basically have the color of the rainbow. The more colors of the rainbow, the better, because why those colors of the rainbow? You get those phytonutrients, the reds, the yellows, the greens, the blues, the oranges, the purples, that confer continued benefit to the body. And then we talk about things like making sure that you're drinking plenty of water, and using that as a substitute for high calorie, sugary beverages. As a matter of fact, if you had to say, like, what are the best foods that I should eat, like right now, like what should I eat that's going to allow me to be healthy, the healthiest, best things to do, I tell people this is my page. I go, number one, fruits and vegetables, get 5 to 10 servings a day. Number two, if you can, nuts, eat a handful of nuts a day. Number three, beans, eat a cup of beans each day. And number four, go ahead and get your 100% whole grains in, things like farro and quinoa, brown rice, cracked wheat, oatmeal, cornmeal. Those are things. And then contrast that with the four worst foods for longevity. And this is the things that unfortunately are what we see on our corner stores and in our food deserts. We see sugary sweetened beverages, which are full of empty calories. We see salty snacks that have too much salt and preservatives. We see packaged foods. We see cookies, candies, and other processed sweets that should be probably banned from our pantries. And lastly, we still see a lot of processed meats that have been linked to cancer and heart disease. So again, the opportunities to change the conversation, but to provide those resources to people that sorely need them. There you go.
I would like to add another barrier, maybe one or two. I would like to talk about the essential workers. Many of the people in our community during this COVID pandemic were allowed to be able to take care of themselves. And if what would happen in the beginning is a lot of these companies weren't protecting them, and many people died. And then the breadwinners were gone. Those who were supporting grandma or grandpa or children. And all of a sudden, there's this economic barrier where they can't even get health care. there are various reasons, whether they're documented or not, and it's not easy for them to find and invest in their own health because one, they don't have time, and two, the economy they're going through right now is bad. It is very bad, and it could be all that. Um, our Latino community is does suffer a lot about with diabetes, with chronic diseases like that, because most of the time what they're able to consume is cheap food because that's what they can afford.
Mm-hmm.
And um, another barrier is when you go out to the grocery store. If you are middle class and you're able to go buy uh you know, natural food that's good for you, that is great. But most of these people cannot.
Can I
And
interrupt you for a second? I
yeah,
have a guy that always talks about whole foods, whole paycheck.
yes.
I mean, that's his
They
motto,
go together.
whole paycheck.
Yeah.
Even recently now with the prices the way they are, my folks and I, we have been able to get some groceries, but not like before, where we try to we make
Mm-hmm.
a list and if we have 20 items, we only brought home 10 because
Mm-hmm.
everything's so expensive and we're trying to eat healthy, yes. But then imagine someone who doesn't have um
That option.
a middle class economy like I do, maybe. And how do they take care of themselves too if one, the economy they're going through isn't at all fair, should I
Mhm,
say fair?
mhm.
And also the system is not allowing him to even purchase health care.
Mm.
Um,
Wow.
Yeah.
there,
Mm-hmm.
we have been trying to find even it's like the enrollment period or it's enrollment period, or you can't buy it because of your legal status. Um, this is where we have these gaps, and they can take care of them. They're trying to go. They get trapped by someone
Wow.
who's, oh, if you take this, you'll
Mm-hmm.
be able to control your blood sugar.
Yes, yes, yes. Talk
Eat
about
and
budgeting
help.
versus the care that they need.
So they see, oh, I'll grab a
Mm-hmm.
box of tea and that should help me. When
Mhm.
they really need insulin, when they really need something that better that'll be able to control their diabetes.
Right, right.
So I think that though you're talking about some stress related dynamics when you start talking about the multiple root causes, as it may be, whether you're talking about income inequality, whether you're talking about
Hmm.
systemic, as it may be, discrimination or exclusions, as it might be. They're just, when you start talking about, man, I got a job, you still got to deal with whether it's enough money, like the lady was saying. Am I going to pay the light bill, or am I going to eat? Am I
Right.
going, when you're having to juggle, keep these plates spinning, and you're running from one to one. When this one slows down, you got to run over there. Then you got to ignore this and that. And what's the old expression? You're robbing Peter to pay Paul, as it may
Mhm.
be, and that creates a stress.
Yes.
And the other part of that, if I can talk about, I have these, I'll call them my congregants, as it may be, people in my church who um, and I say this as cautiously as I can, is that I'm just going to pray about it. When you
Mm.
need, and the fact is, are you praying for the money so that you can go to the doctor? Are you praying for the money so that you can eat and the thing is, you find yourself um, not knowing how to appropriate what, and you say, I just hope God will take care of it, as it may be. And that is such a difficult place uh, for a pastor, as it may be, or for people who are in ministry oversight. You know, because you almost have to say, dude, you need to get a job.
Yes. Yes.
Sister, you need to go to the doctor because you've been coughing like that for a year. Yes. You know, and whatever those root causes are, is that I want to go to the doctor, but I can't afford it.
Right. Right.
You know, and so our healthcare is because of those disparities, as it may be. Me personally, I when you start talking about the importance of a primary care physician, being part of a group health plan on my job, I for a couple of years, or 3-4 years, in fact, I had about 3 or 4 different doctors because I was in a group thing.
Mm-hmm.
It wasn't until that fourth one that I decided to make her my primary care physician, because she was the first one who really identified my PSA numbers. And the fact that hey, African American males, this prostate thing is a real deal, dude.
Yeah.
And I say that from a perspective of those other 3 physicians, and whether they didn't place a value on it or not, but I can kind of remember that being mentioned. But it was like, you don't have to worry about it now because the numbers are so low. But there are some indicators there, which are PSA.
Sure.
The African American female said, you need to go and get this thing looked at, because your numbers from over time have kept on progressing. The doctor that I went to said, well, it's just progressing, but it's you know, you can wait a little bit more. And I'm saying, wait a minute. What do you mean I can wait a little bit? Is it going to wait with me? I'm talking about the cancer.
As you get older, that number gets higher? Is it because with your age?
Yeah. So let's deal with it while I've got a chance to win.
Right.
You know, and so, and you know, and I say that from a perspective of being, you know, a 10-year cancer survivor, where my PSA numbers have been 0, 0, 0 since then. But I don't know where I might have been had I allowed that. And I say this with all due respect, European provider, as it may be, to say you can wait.
Yeah.
Whereas the doctor, the lady, you know, the African American, and whatever that means, it means that she had a greater awareness of the urgency of that.
Yeah, and action for that as well.
Yeah.
Mm-hmm. Yeah. Maggie, what were you had something to say, and then Dr. Jasmine.
Yeah, so I wanted to just add to the comments that Julieta mentioned here, and just to add to the equation, if you are a migrant farm worker, then yet you have so many more barriers. You know, everything that she mentioned certainly is barriers, but with the migrant farm workers, they're mobile, so they go from place to place, and they're moving from state to state because they follow the different crops. And another barrier that they have is the fact that when they are in the farms, they have little to no access to medical services. And that's why the health programs that the Illinois Migrant Council provides are so crucial to their health, because these are the programs that we actually bring to them. We go to the farms with wellness vans, and we get in there in the farms with the permission of the growers to conduct different assessments while they're there. A lot of them don't have transportation because the growers do not allow them to have any transportation while they're working there. So it's just like never ceases to amaze me on how many similarities both of our cultures have, and how much we lack in the services that we are entitled to or should have, and how much the percentages of even infant mortality are within our communities. And
I have some numbers on that.
Cancer, incidents that go undetected until sometimes it's a little bit too late. We also run the programs on cervical and breast cancer awareness, and we bring those services to the communities. And the other thing that we do is that we follow them with referrals. So if they are coming from Texas and they get here and we identify a health issue with any of them and they move on to Wisconsin or Minnesota, we make sure that we connect to wherever they're going so that they can continue services.
That was sorry, let me interrupt. That was my question to you, Dr. Maggie, is that, as you said, you're going out to those folks who are migrant and they're moving around and you're providing care for them right where they live. My question was, how do you then transfer that information if they're moving around like that? Because then how do they continue that care? So there are other, you're saying there are other organizations similar to the immigrant organization that you work for in these same farm communities in other states?
That is correct. So we have sister organizations that are like us throughout the country, including Puerto Rico, and we have a consortium of different organizations that work together, not only for the health programs, but also for the migrant education programs, because we get the kids that are coming from Texas, California, Florida, Georgia, and they come from different educational systems. So we have to maintain a consortium and a linkage so that the kids don't fall behind. A lot of the kids are able to get detected of any kind of illness that they may have, so that we can make sure that when we get them here or they go to another state, that they are being taken care of so they don't fall behind or they don't drop out of school. So there's many different things that come to the radar when we identify health disparities among the migrant farm workers. And I think it's also very important for us to be able to share with the groups that we come in contact with that there's a huge difference between migrant and immigrants.
Yes.
And these two different, I guess, titles, for lack of a better word, sometimes get confused because migrant farm workers are 100% U.S. citizens, that they just migrate from one state to another because that's a way of life that they've had for generations and generations.
Sure.
But immigrants are those that come from another country and have made the decision to move for whatever is it that is happening in their own home countries and come here. And then if you also throw in into the equation the H2A, which are the laborers that come from other countries.
Yeah. Yes.
That are only here temporarily. I think the longest is like 6 months. Now we're talking about not only different cultures, but different languages. We provide services in 4 different languages because we get people from Haiti, we get people from North Africa, we get people from the Philippines. So we have to be able to communicate with them to be able to provide the services while they're here. In addition to know what services they are eligible for and what they are not eligible for, so we don't jeopardize their legal status.
That's awesome. I need you to put the name of your organization in the chat, because what happens is once we have this conversation here today, and we have a few listeners that are online with us, we publish this on YouTube so that other folks, so that a larger audience can hear it. And again, our whole purpose is, sure, we're talking about the disparities, but we want to talk about what some of the solutions are, and that is definitely a solution. Dr. Jasmine.
Yeah, I just want to piggyback off what Julieta brought up earlier about essential workers, and then those when they go out to the grocery store and not able to find healthy options for food and have no option but to go to work, and how as a society we prioritize their health. I feel like many people in their position, they're in the role of caregiver, And so a lot of times maybe prioritizing the health of others in their family or prioritizing other things like making sure they have a roof over their head before seeking health care. And just a lot of the things that are not directly healthcare delivery, there are many factors that influence our health. And so one of those is our built environment. And so that's the places where we live, where we work, where we play, where we pray, where we learn. They all impact our physical and mental health.
Mhm.
And there are so many, that's what we call social determinants of health. But there are so many ways in which both structural and institutional, the legacy of structural and institutional racism has its ramifications today. Um, and the way it works is it's meant to be covert and invisible, but it has a profound impact on our health. And it is through policy that we begin to change that. It's also through action. It's also through people who need the help. So we actually listen when they ask for help.
Excellent. Dr. Gomez.
Mhm.
Dr. G.
Yes, I wanted to talk briefly about the Affordable Care Act because we haven't really dived into that yet. And so, when the
Yes.
Affordable Care Act was, when we're talking about health inequities, when the Affordable Care Act was signed into law by President Obama prior to 2010, um, obviously health disparities were quite significant, and so many people were uninsured or underinsured. So once the Affordable Care Act was signed by President Obama in 2010 into law, between 2010 and 2016, there were actually large gains in coverage across racial and ethnic groups under the act because it gave us that kind of access. And so you're looking at everything from all sorts of people of color. However, in 2016 or 2017, well, let me say one thing that's, let me take one step back. During that time of more people getting health coverage, people of color were still more likely to be uninsured. Then in
Yes.
2016, 2017, there's actually a plateau. And this was published by actually the Kaiser Family Foundation. But there's actually a flattening of the curve. And actually, as of 2019, when you look at non-elderly American Indians and Alaskan Natives, Native Hawaiians and other Pacific Islanders, Hispanic and African American people, they actually are seeing a gain. So a gain in the likelihood of lacking insurance compared to their white counterparts. So we did something, it worked, and then it flattened out, and now we're seeing a rise in the uninsured and the underinsured. And so it's a tall task of what we know we're up against. But we have to acknowledge what we're up against and then try to chip away at eliminating those barriers. But I wanted to just make sure we talked about the Affordable Care Act and some of the challenges that still remain.
Tell me more about the Affordable Care Act that our communities can take action on.
Yeah, so I think that this is how we do it. We have partnerships. You have to have find out who are the community stakeholders. There's a
Okay.
lot of people that are trying to do a lot of the same things, but the best partnerships are going to be the policymakers and then the people that are delivering care. So public-private partnerships between community groups, community organizations, and health systems. I think that's really where a lot of it's going to be. And a lot of health systems are actually having those conversations and forming committees of diversity, inclusion, and cultural competence and health disparity committees. But now it's actually tasking those health systems to put their words into action and put the money where their mouths are. The great thing for my health system, and I'm not a spokesman for Edward Elmers, but I will say this: Edward Elmers has established a community fund of approximately $100 million. And that money is going to go to organizations that are out there trying to end disparities, trying to get more access. And so if you want to make change, you got to put money into it, but you got to hold these health systems accountable and say, hey, listen, if you're truly going to be a community, a health system of the community, let's do things together. And what the community organizations can do, because they know the nuances of the communities in which they reside. The
Right.
hospital's looking at it maybe from a macro view, but then you have community organizations that can look at it on the granular level and take
Yeah.
those funds and then implement them and put them into play. So that's my take on things.
Could
gotta
you
do it,
put
though.
that organization that you just mentioned, you called out an organization that's giving out this 100,000?
Oh yeah. So I can put it into the chat. It's actually my health system.
Okay.
Edward Elmer's Health has actually established a fund that will. So Edward Hospital, Naperville, Illinois, Edward Elmer's has established a fund to which is a community action fund, which will part of that money, a good portion of that 100 million that they've said that they've invested, that their invested community is going to go to help close gaps.
Amen. Amen. I have some stats here on healthcare coverage, and it actually stems back to 2017. It said 10.6% of African Americans were uninsured, compared to the 5.9% of non-Hispanic whites. 80.4% of African Americans had healthcare coverage in 2017, compared to 94.7% of their white counterparts. And then in 2017, 16.1% of Hispanics were uninsured, compared to 5.9% of non-Hispanic whites. And then 83.9% of Hispanics had health care coverage in 2017, compared to the 93.7% of non-Hispanic whites. So there's definitely a gap there. It is the number that are actually uninsured is, or I should say, the number that are insured is much greater than I expected. But then again, that number of uninsured, even though it seems small, like 16.1% or 10.1% of a nation, is still a large number.
Hey, Elisa, can I say something? Because and I want to tell people where those numbers came from.
Yes.
You mentioned the 2017, but I think we have to go back pre-Affordable Care Act. And so the numbers of Hispanics in this country back prior to 2010 that were uninsured, at least according to the Kaiser Family Foundation, was about 32.6%.
Okay.
So to go down to the teens, that was a movement. But again, it's flat. It was flat in 2017. Now the numbers are up. I think the most latest data out of a Kaiser Family Foundation from 2019 was about 20.0%. So 32%, 2010, now 20% of 2019. African American, the numbers, because I'm looking at them right now, actually I got to pull up. Numbers of African American pre-Affordable Care Act was about 19.9% of uninsured, now roughly about 11.4% as of 2019. So numbers came down with the Affordable Care Act. Numbers got flat. Now they're all coming up a bit to 2019.
Right.
Yeah.
So, it's and then even though affordable care, you still can have those options. I know, just dealing with my mom and helping her with healthcare, it's understanding, again, that education on how to select healthcare, maybe it's a larger deductible, but then if you're able to go to the doctors that you need, or if it's in your local area, it's being able to navigate how to make that selection. And again, even as we've talked about the language, and I know we always talk about Spanish, but we have our Polish Americans and our Asian Americans, and our, who still, they may have a difficulty in navigating that language in order to get the best health care and insurance that they may need. I am needing to hear from Dr. Allen. I know it looks like you are searching for some of your research down there, and as you do that, I'm going to go to my next, and we only got like 6 minutes, people.
Well, we having a good time though. Let's be honest. I'm having a great time, y'all.
We're having a good time here. Dr. Jasmine, did you have your hand up again, or was that from your?
Oh, just to mention quickly, part of also what influenced the number of people who can become insured through the Affordable Care Act is that each state was left to decide whether or not they would implement this. So we call those Medicaid expansion states. So there were several states that did not decide to expand their Medicaid program. So that also influenced access to healthcare in those states.
And did you say, I'm sorry, did you say Medicaid or Medicare? Dr. Jasmine, did you say Medicaid or Oh, you're on mute. You're on mute.
Medicaid. Sorry, I didn't realize
Okay.
I was on mute.
Okay. So you're saying each state had the opportunity to make that expansion. I see you posted the article. Thank you. So that our audience can actually check that out. But then the decision was based on the states actually expanding it versus not.
Yeah, but we're fortunate for Illinois that we have expanded it here in Illinois.
Mm-hmm. Illinoisans, I hope you hear that. Take advantage. So as we have 4 minutes left, I'm just going to drop down to our last question. Number 5, aside from new legislation to address systemic racism and all the healthcare barriers that we've talked about today, what are just some basic tips that to educate people of color concerning taking control of their healthcare? Just a basic tip that they can go out and implement if they have the time this weekend. Dr. Allen.
I was listening to all the other experts, but my big thing is that I would ask long term that we need to build more HMOs in Black communities so that we don't have so far to go to hospitals and other centers. When you put an HMO like in a community center or near a church, the interaction that normally happens there has an exponential effect. So if I were to talk to the president, I would say in all the areas where Black and Latin people live, let's build HMO facilities. Let's put the money there. Let's put the doctors there. Let's put the people there, the healthcare, the diabetes education. Let's put it where it's needed the most. And secondly, I don't know how many of you watch the Black News Channel. It's only been around for 2 years. They're celebrating their 2nd anniversary. Every week they have experts in health care. We'll talk about all the things that we're talking about here tonight from different cities, Baltimore, New Orleans, LA, Dallas, Houston, or whatever. So I would say that's a resource that everybody who has a cable system or whatever, or even the internet, can tap into for recurrent information beyond what we can do right now. So those are 2 practical things I remember. Now, everybody does social media. For those teenagers, you got to link it to their phone. You got to link it to an app. TikTok, Doc, you got to do the TikTok and all that kind of stuff. If you want to reach these young people, that's what you have to do. I'm quiet. I'm done.
Thank you so much. Thank you so much. Dr. Crawford. Again, Dr. Crawford.
Ditto.
Ditto.
Dr. Allen, access is the most important thing to avoid overcome a lot of the disparities. Just access.
Yes, access, exactly.
Yeah.
Because
Julia.
sometimes it's just that. We need more accessibility where it's needed, so many of the areas, they have to go to the next biggest town to get care, and where it may be like a half an hour from where I live. And if when an emergency, that's a bit too long. And what if they don't have a car to go there? What if things going on? Currently, right now, transportation is pretty difficult too.
Mm-hmm, mm-hmm.
Yes.
Dr. Jasmine. I saw you post. Oh, no, that was me. Go ahead.
So I would say that at least as the health department, we could work to find the mobile clinics that are out there and partner with them. So similar to what Dr. Allen mentioned about having those clinics near community resource centers. Some of the mobile clinics are able to travel and set up times where they would be available consistently in the neighborhood. So I would think that's one example. An individual can go to the website hrsa.gov to find their nearest federally qualified health center. They're usually in many community neighborhoods. And then last but not least, for individuals who may be experiencing, so this past year has been past 2 years have been very hard, both in terms of stress, grief, depression. So individuals who are having any symptoms, can actually, so some of these may be having difficulty concentrating, not being able to sleep, having changes in appetite, not being able to enjoy the things you did in the past. It's always a good idea to get some professional advice. So you can work with a clinical social worker, a licensed professional counselor, or even your primary care provider. And these professionals, they can actually walk you through an assessment to see if you do actually have depression and anxiety. And if you are positive for these conditions, there's treatment available. And that treatment can include talk therapy or medication or both. But again, your clinician is a partner in helping you achieve your health, and it's a decision you would come to together with your clinician.
There one comment about the mobile clinics. I've been thinking about that the entire week.
Yeah, so in Chicago, on the west side, we've worked with mobile clinics that were supported by COIP Community Outreach Intervention Project, and looking at mobile harm reduction services like Chicago Recovery Alliance. We have a meeting with outreach workers in the area once a month and go over areas where we know overdoses occurred, many overdoses occurred, and we help coordinate the outreach, the harm reduction outreach services, and then also those mobile clinics to make sure that they're on the locations so whenever an individual, not only just to respond to overdoses, but to speak to those who hang and congregate in the area, to provide them with naloxone, which is the medication that prevents or reverses opioid overdoses. And if they want to engage in treatment, that option is there. They can immediately have access to it.
That's excellent. Dr. Rivera, final tips? You're on mute still?
Okay, for me, it's all of the above. in addition to education.
Yes.
You know, it's so important to get educated in every aspect of the word. Knowledge is power. Knowledge is prevention. It's preventive care, so that you don't end up with long-term illnesses that sometimes cannot be reversed. So that is our motto for us with our health programs, is we educate people so that they can have a healthier life, and we also help them convert healthier lifestyles and have better choices of many different things. It's not just the healthy eating, is the exercising, is the passing it on to other generations, because you cannot do one without the other. It has to be a whole family, a whole community journey to be able to prevent all these illnesses that a lot of the times people do not have the money to be able to get the medications or to get the treatments that they need. So if you prevent, you will be in the long run saving you a lot of money.
Yes. Thank you so much for that. Dr. G, did you give us that last final tip?
Sure, I'll give it just a couple of things. And this has been, first of all, thank you for inviting on behalf of just myself and being present with all these other experts that are really trying to make the world a better place. And I say that with all sincerity. I just want to thank you all for just sharing the floor with you guys today. My final thoughts are this. Number one, I'm a primary care physician at heart, so I would say this. See your primary care physician once per year. Get your annual physical. If you haven't had one in more than a year, go see your doc and get your annual physical. Number two, invest in yourself and make health a priority. We just have to have that insight to move ahead. Number three, the more success you have with your health, the more likely you'll have success in your life. And I think that's paramount, and it's pretty understandable. Number four, if you see someone struggling with their health, then offer them kind and compassionate and non-judgmental encouragement. I think we have to. Kindness is everything. Number five, eliminating disparities in health coverage is an important component in addressing longstanding racial disparities in health. So we have to have these conversations, and to address those inequities, we have to have, we can address the inequities within the health system itself, the inequities within social economic factors that drive health, and increasing the diversity and inclusion of people of color who either shape health policy and or provide care. And then lastly, I'll say this on a philosophical note, we are not judged by what we do in life, but rather we are judged by the lasting impact our actions have on others. There you go.
There you go. There it is. Well, thank you for those words, everyone. Everyone, thank you for your input. Thank you for all that you've offered here tonight. I've tried to capture as much as I could in the chat because, again, once people are watching it again on YouTube, they'll, even though they'll hear it, live, they can see some of the tips that you all have shared with us, and not just talking about disparities, but what we can do individually as well as collectively to I won't say eliminate right away, but to continuously chop down that tree and work on being the change that we want to see.
Yes.
So you again, each and every one of you. Thank you to those who have stayed on and been in our audience, and everyone have a wonderful evening as well.
I want to say thank you as well. I don't mean to cut you off, Elisa, but I just want to thank every one person. I thank you, Dr. Jasmine, for answering the phone when I called, and definitely, Dr. G, I'm glad I finally got you available. So thank you so much, and Dr. Allen as well. It was good to talk to you. I haven't spoken to you in a long time, and Larry Crawford, it was great. So I just wanted to thank all of you all personally.
And I want to thank Barbara. She came in and she said, I think I know a couple doctors that I can contact and see if I can get on the phone. So she did, and she got these 3 amazing people and then we also collaboratively worked to bring in Dr. Rivera and Julieta. So I appreciate your organization, even taking the call when we said in the chat, hey, I'd love for you to be a part of this conversation, Dr. Rivera. So again, we appreciate each and every one of you for participating. Don't think that we won't call you again, because we will, as we continue these community health worker conversations for our community.
All right. Thank you.
Thanks, guys. Peace.
Thank you all. Have a good evening.
You too.